Welcome everybody to this afternoon's webinar focusing on Parkinson's and medication. We thank you for joining us. We also thank you, BL, for sponsoring this, this continued educational event for us as Parkinson's clinicians during this time. And obviously we also thank the Academy for allowing us to do this and to give us all the support we need to do it. Once again, we have an excellent and experienced panel looking into the practice and safety regarding medication during this time. But of course, these are practices we're likely to take forward virtually with a lot of our caseload moving forward. So it's going to be valuable ongoing. The biographies for the speakers are available online. But please bear in mind, these are our experiences on the whole that we're sharing, but please do feel free to share your experiences or to post some questions through to us on the chat if you wish to do so. So briefly, we have Annette speaking to us, Annette Hand speaking to us about medication in the newly diagnosed during lockdown. Jane's going to cover the review of medication through virtual consultation. Patsy's going to talk about medication and self-medicating in hospital, and Louise is going to draw it all together for us with some really valuable case studies. So I'll hand over first to Dr. Annette Hand on medication in newly diagnosed during the lockdown.
Thank you. So I'm going to talk about starting medication in the newly diagnosed. This is something that I've been looking after people now for a long time, and part of my role as a nurse consultant is seeing people at the very beginning of their journey and diagnosing Parkinson's in the first place. So you'll see that the service that I have covers up in the northeast of England, covers up in Northumberland here. And we have about 12 medical clinics per month. So actually, pre-lockdown, I could be spending at least 2 or 3 hours driving to some location for clinic. We have about 12 medical clinics I cover per month. And each month we have about 60 new referrals coming through to our team and service. So we have an awful lot of kind of people coming through our doors on a very regular basis, brand new. The thing we've had with COVID is actually from March 2020, there were about 200 referrals sitting there, either with the appointment to be seen over the next few months or actually still waiting for an appointment. So there's an awful lot of people waiting to be seen. And like everybody else, we weren't able to do home visits or face-to-face appointments in clinic, and all our clinics in hospital were cancelled. So really we had a choice. Did we postpone all our new appointments? But for me, that had massive implications. I don't see how we could say no to 200 people and postpone appointments that people have often been waiting for months anyway. We had a choice then of offering either telephone assessments, and we could do that anyway. But luckily our trust started with Attend Anywhere very quickly on in the process. So that was a method of seeing somebody very early on back in March. So for me, telephones, still some people don't have access to a phone, a laptop or a computer to carry out a video consultation. So we have been still carrying out consultations with new people via the phone. But when I've been doing that, to be honest with you, I often find it's very difficult to get a full history of somebody, whether it be medical, social, or medication. Trying to get some description of symptoms that people have, again, is very difficult when people describe, and often you haven't got a shared language that you're using. Often people describe the tremor in very different ways to what you expect. And when you see somebody actually in face-to-face, they could be looking very different. And I've experienced that certainly with having a telephone consultation and then later being able to do video consultation. For me, I suppose on the phone, all I'm really trying to do is to determine if there's any worrying neurology. So for me, yes, I picked up things like brain tumors, non-peripheral hydrocephalus, and other conditions that actually could be life-threatening. So those are the main questions I'm trying to ask about on a phone call to make sure that those things aren't there. Because if they are, then I'm trying to get somebody in for an urgent MRI or a scan or an appointment. But on the phone, I would never diagnose somebody with Parkinson's, and I certainly wouldn't start somebody on treatment for Parkinson's over the phone if I've never ever met them before, because I don't think for me that's personally safe. So what I'm going to talk about really is Attend Anywhere. So this is our platform that we've been using for video consultations that we can use in the Northeast. All I have to do is send people this link, and then we secure a time and a date that they'll click onto that link, and then I can see them face to face. And for me, that's been fantastic. Because if you see my background before and the location that I have, actually being able to see somebody up in Berwick where I don't have to get in my car, spend 2 hours, 3 hours traveling there and back again has been amazing, both for me but also for them. So again, we've been using this for an awful lot over the last couple of months. So when somebody dials into this, they'll come into my waiting area, and we've set our clinic up actually at 12 hours, so anywhere from 9 till 9, you can see on here. And also we've been doing the clinics 7 days a week. Not that we've been doing an awful lot of weekend work or evening work, but that facility is available to us. And certainly our manager have said to us, if we want to do that, we can do. I have seen a few people who are actually still working, key workers themselves, and caught up with them in the evening or the weekends. And the great thing for me is I can do this from home. So I have this on my laptop at home. I can use Attend Anywhere. It's all secure. It's all NHS. And the other really nice thing is I can link in other family members. So even if somebody lives at home alone and they're brand new to us, if their family member also gets the same link, I can join them in the consultation. They can sit there. So they could be in the same town, city, or they could be anywhere in the world, but at least then the person with Parkinson's that we're looking at renew isn't alone in the consultation, and we can have a full family discussion as we would have hopefully done if they come in to see us in a face-to-face visit in clinic. So the other one thing I have that's really helped me is System 1. So this is our electronic record, and this is just a snapshot of the front page that I'll have for a newly diagnosed person coming through the doors. So this is our new patient assessment. So on this, you'll just see the different tabs that we go along to. But for each tab, there's multiple kind of pages within that, looking at assessments. So again, getting a full history, information, background, family history of Parkinson's, history about the blood pressure, the medication, cardiovascular, gastrointestinal. And I've got everything here, and I'll do a full systems review as well. I've also got the MDSU PRS on this system. So again, I can do this face-to-face on a video consultation. And the only thing I can't assess for obviously is tremor, is rigidity, but I can still get somebody to stand up and walk across the room. I can still look at gait, I can look at balance, I can look at handwriting. I can all those things quite clearly on the video, which has been really helpful for me. Also with System 1, I can access all their blood results. So I can go into ICE, I can organize a DAT scan or MRI scans or anything else they've had available to them. So for me, this is one way to make sure that my assessment for a new patient is really thorough and really clear and concise. The great thing about System 1 is, though, the majority of our GPs in Northumberland are also using this system. So as I'm typing into this, this is a real-time record. So actually the GP can access that record again straight away. And again, this is just a snapshot of somebody that's brand new to us. So we have a whole kind of series of tabs down this left-hand side about the Parkinson's assessment. But anything I type into that assessment, it all comes up very clearly here, and then gives a really clear understanding of history about how I come to that clinical diagnosis and how I've been sure about that diagnosis of Parkinson's in the first place. So again, this is something that for me is really important because it's an electronic version, it's real time, GPs access it straight away, so we all know what each other are doing. So when I see somebody brand new and I fill this in, and then I have to think, okay, this is Parkinson's. To treat or not to treat, and that is a question about we have to ask about, not only during this time in COVID, but also when we see somebody face-to-face in clinic. So NICE guidelines, again, haven't changed at all from 2017. So do symptoms impact on quality of life? If yes, then we're looking at offering levodopa, and if no, then we can offer any other choices. To be honest with you, everybody that I've seen over the last 3 months who I've felt had Parkinson's, symptoms impacting quality of life, everybody's taken up the offer of levodopa to start off with after the consultation. And again, I think lots of people are finding that earlier on makes a big improvement in quality of life early doors. Again, guidelines are telling us, all right, that we need to have to think about symptoms and lifestyle and choices and options. And again, it really is a juggling act about how somebody is. Talking now about how people are in lockdown and COVID is very different to what people were like before at home time. There's a lot more anxiety going on. There's a lot more inactivity going on as well. People have been more anxious and certainly symptoms have been more aware of that. Just trying to manage what was pre-COVID, what is COVID now, and how best to treat those individuals. The biggest thing for me, I think, is reality versus expectations. When you talk about Parkinson's, it's about actually what can we do about it? What can the medication do to improve some of these symptoms? So this is really about an information sharing exercise at this point, not to be me about an information giving. What is it the individual wants to achieve out of medication? What is it they're hoping to expect? What is it they're hoping to see if we start drugs? And again, it's very much talk about what the drugs will do, how they will work and how long it will take for them to work, what will get better and what won't. And again, talk about the side effects really early on. So again, that video consultation is really good to be able to make sure somebody's facial expression or responses to what we're talking about are very clear within that you would never get over a telephone call itself. Highlighting the risk of medication, again from NICE guidelines, talks about when we're starting treatment for people with Parkinson's, we've got to give them and their family members information, particularly on impulse control disorders, excessive daytime sleepiness, and psychotic symptoms. And not only have we got to give them that orally, we've also got to provide them with written information. So again, I've been often emailing information around, signposting to Parkinson's UK information about the medications, posting out information that goes along with that, and having very clear discussions in my letter that I send out to them from that consultation about the side effects we've discussed, the potentials for those. Not now is okay. I think sometimes people think, actually, you've been diagnosed with Parkinson's, I need to start treatment. Actually, people don't. We can give it a bit of time, we can delay things a bit. And we all know that if you're an inpatient, Friday afternoons and evening times, if you're going on holiday, actually, those aren't the greatest times to start a brand new treatment. And again, some people could say the same could be saying for COVID-19. At the minute, we need to give people a bit of time. So if actually they don't feel they're quite ready to start treatment yet, that's okay to do, so reassuring them that not now is okay and they can wait a bit longer if they needed to. The other part of this, I've got system 1 here. So this is showing you what happens then if I decide to start treatment. So on this button here, I've got new medication starting. So here I can press new acute, and within that I can put detailed assessment of what I want. So if I want to start on cobenl-dopa, 62.5 milligrams, 3 times a day, I can put that into that whole system, and that'll go into their actual patient record that they have within secondary care. I then also have a leaflet that I've produced, or a questionnaire that I produced about starting new medication. Have I gone through side effects, how the medication works, what the patient expects will get out of it. So it's a very clear, detailed account of what we expect to get the medication improvements we'd expect to see. Again, recording allergies or sensitivities, talk about impulse control disorders, talk about side effects of medication. Another nice thing about this is I've got titration sheets here for levodopa. So both for co-carbidopa and cobenl-dopa. Yeah, I know it says co-carbidopa for them both. That's a slight error, but I've got on there in the background, if I click onto one of those, it'll bring me up the titration sheet that we use over the 5-week course. But it also, and it automatically pulls patient details through. And all I have to do is put the timings of this that I want them to start. And again, I can email that directly through to the patient themselves, or again, it goes directly within the GP record. So it's a really simple way of making sure that we're all understanding about, if we're starting a new treatment, you know, today, about how that's being done and why it's being done and what we expect to get out of it. If I was in clinic, what I would normally do is I would normally give somebody a prescription to take away with them, because I would start that treatment to make sure they were okay on it. I can't do that at the minute, but with system 1, what I can do here is I can task the GP. And that means all I need to do is click a button, send a message directly through to GP surgery, asking them to start, as I have started on the acute, and actually that goes through same day. So still the patient can still pick up the prescription on the same day as I've seen them, all right, on a video consultation. There's no waiting around for a letter, there's no waiting around to be seen, you know, for several weeks, and it's very clear about what we're looking for. And again, automatically will bring up the patient's medication there, and as you can see, I've got cobenl-dopa here, and the titration is starting off. And again, I can clarify when that's been started, or what the time frame is that, to make sure a patient has got it and it's correct. So actually having system 1 has been a godsend for us to make sure that our communication is really good, our safety netting is really good, and we can actually improve starting medication or real-time medication within that. So for me, that's really a helpful tool for keeping me safe. How do I measure response? Just as I would do normally, asking people to put a list of kind of the problems they have, putting that down at the very beginning, putting that way when they start treatment, and then having a look at that again at the review process to see what's got better. Because often these things do take time, and it's about being realistic, and often people can't remember what they were like at the very beginning of their journey, even over 5 weeks. If you ask me what I was like last week, I couldn't tell you. So it's really helpful if I kind of make people think about it and do that as in a partnership. So not only with the person with Parkinson's themselves, but their loved ones around them, asking them to write little things down, putting away not to obsess over it, then have a look at that at the end, and we can go through what's got better and what hasn't. Again, it's really important to understand that not everybody will take the medication as we'd expect. So we know that those obviously who are living alone aren't so good, or low income, if they've got other things to kind of like concentrate on. But certainly the major things are, for clinical point of view, is poor knowledge of Parkinson's and complex regime. And that's really why it's important at the very beginning of their journey, they've got information about Parkinson's and about the medication. They fully understand what it's all about, how the drugs work and how to take them, to make sure they take them correctly. But also it's making sure that they're not on loads of other medications. Actually, if I add in a really complex regime, that they're not going to adhere to that. So it's just acknowledging that those are there and making sure we're trying to tackle those at the very beginning. Obviously, people talk about lots of their non-motor symptoms too, from everything from their sleep, bowels and bladder, as we all deal with. Early doors, it's about clear assessment of those things, information, understanding, very much conservative advice, signposting this point of view, and I'd only treat if it was really necessary, but still have that back in my mind if I needed to. follow-up process is really vital for me at this point in time. I must admit, I've been doing that more often and more frequently than I probably would have done if it was face-to-face in clinic, but certainly making sure they've got a helpline number, they know what to do out of hours if they're running into difficulties, and having a very clear date for review. So what the date will be, what the format will be, is that face-to-face or telephone? Who will that be with? Is it with me, or is it with a Parkinson's nurse in the team? And again, signposting for further information and support. Keep staying active. Again, really important in a minute. We've got lots of information around that. And Parkinson's UK just produced this really lovely sheet about how to stay active, even at home, with chair-based exercises that we can all access. And again, it's online, so it's been great then to be able to just pass it on to patients and make sure they've got some information there if they've needed it. So, attend any time. I think I was quite apprehensive when I first started this, thinking actually, could I diagnose somebody remotely? And these are just 2 patients that have kind of given me their feedback on this. And what I would say is actually it's been really amazing. We've been able to reduce our waiting times by, from months down to, even days even. And people have really enjoyed being in their own home environment, being able to be more relaxed in the consultation. And actually it's been really helpful. So I feel like much more confident in being able to diagnose, but also to treat somebody during lockdown. And I'm hoping that this won't be just the end of it. We'll be able to use this for the future too. So that's been really positive, and positive feedback from patients. So it still means you need a comprehensive face-to-face assessment. Again, that can be done remotely, as I said, via video consultation. I couldn't do over the phone. Managing medications within a legal framework. It's about clear documentation, about following nice guidelines still. It's about being safe in your prescribing practices. Managing expectations, clear and accessible records, and I certainly have that with System 1, careful safety netting with helplines and support elsewhere, and again, that clear review process. So it is challenging, but it can certainly be done with COVID, and it'll certainly be going, as you say, Alison, this won't finish anytime soon. So it's about finding ways of working and keeping new people being able to be seen in a timely fashion. Thank you.
Thank you, Annette. There's a few questions that came in, but one I also wanted to add, so I'll treat you to my one first. Have you, I mean, it was really positive, the feedback you had from those patients, but have you had any sort of very awkward, uncomfortable, challenging responses to the process of diagnosing online?
No, to be honest with you, most people were relieved they could be seen. Often people were thinking they would be postponed for several months, and I've been able to phone them up and actually arrange, assessments very, very quickly with them. So people have been seen sooner than they were actually been done if we were face to face. And I think nobody that I've spoken to who've had a video consultation has been upset or distressed by the process. Lots of people have found it very reassuring, actually. And very good feedback.
So possibly something you will take forward for those long distant places that you wouldn't be visiting so much. Thank you.
Yeah, I think it needs to be in a toolkit.
Thank you. And one of the questions that's come in, maybe actually 2, what would be the best intervention for a patient with PD with severe bilateral hand tremor? It might not be a newly diagnosed person if they're bilateral hand tremor, but...
Yeah, the thing is, bilateral hand tremor, I wouldn't think that would be early doors. You'd look at unilateral symptoms. Again, it'd be careful history, because I wouldn't expect to see Parkinson's bilateral to start off with. We all know that actually there's very few medications that improve with tremor. You've used levodopa, some anecdotal evidence about pramipexole, but I think if it's newly diagnosed, it's bilateral, then I'd have to think, have we got the right diagnosis? I have even been using propranolol, I must admit, even for Parkinson's tremor, with some benefit. There is some evidence, that's been anecdotal to show that can help too. So I think it's just kind of knowing what they have or haven't been tried already and having a look to see what the options are.
Lovely. Thank you very much. We may have some questions again at the end if we have time, but we'll move on to Jane now about medication generally and reviewing that in this period of time virtually.
So thank you for that really comprehensive presentation, Annette. And I'm going to pick up on a few of those issues. I'm going to be talking about the principles of a medication review and the things we need to keep in mind, particularly now during this COVID-19 pandemic. So why do we do medication reviews? Well, I think really it's about checking, isn't it? What's going on with a person's medications, their concordance, what we think they're taking and what they're expecting to happen from the medications that they're taking, what we think they're taking and what we expect to happen. And are there any adverse effects that we can pick up on that we might need to address? I think as well, we need to be looking at, is there anything we need to change? And Annette alluded to this, that there's not always that urgency to do anything there and then, especially now. And I'm going to talk about that a little bit more later on. Sometimes people are surprised to know that it's coming down with medication that might give them the benefit rather than always increasing medication, which is sometimes what they might be looking for. And I think we need to still think about how we'd be addressing this if the person was there in clinic with us. Something I'll always do is ask people to bring along a repeat prescription or their actual medications and looking at the box and seeing, are they taking them as we think they are supposed to be? How many have they got there? You know, if they've got a surplus of drugs, are they actually taking them? Is something perhaps been tried previously that's still on the repeat prescription, that's still being ordered, and the cost and the waste there? So we need to always still remain vigilant about that, even though we're not seeing the person face to face. So I think it's remembering that even though you might not be seeing somebody face to face or remote, you still need to be practicing within your scope of practice. So if you didn't prescribe before, if you didn't change drugs before, you still need to be using the same process that you would have previously to advise on medication changes. If in any doubt, as we've always said previously, check with your own medications management team. This could also apply to people who've been redeployed to other areas where their prescribing formulary may have needed to change. Again, check that with your own medicines management. I think you'll see there I've put, it's important that reviews remain timely, and Annette alluded to that with the opportunities we still have to do this now, even over a remote access, and that what we're doing should be reasonable and proportionate. I think during this current lockdown with the restrictions, we wouldn't be looking at doing a massively sweeping change to drugs where we don't have the access to go in and review somebody. So it's about, I suppose, damage limitation really, and trying to keep things stable, acknowledging and discussing with the person that this might not here and now give the best optimal treatment that we could hopefully eventually aim for, but it's doing things very gradually to kind of to help support them during this period. I think as well, it's important to remember that whatever you are doing, Annette said about the importance of strict record keeping, and I think it's important to record in the records the circumstances under which you're making this recommendation. So I know Annette said about not prescribing for somebody she hadn't met, and I'd fully endorse that. But certainly when this lockdown started, I had some patients referred to me that had been newly diagnosed in a clinic by a neurologist, referred on to me with some suggestions about you might want to consider starting this or this, and a few options that they might have thought reasonable. But Jane will discuss this in detail with you, and you can have a chat around it. So even though I was still doing that over the telephone, I was basing my recommendations on something that had been considered in the initial assessment. That doesn't take away from the fact that you are still making that decision, you are still taking the onus for the prescribing, but it's about documenting what you've based that on. Because obviously if you were going to say to someone, well, this is what was going to happen, but now because we're in lockdown we're not going to do it, that could be extremely distressing for someone. So I think before you alter anything, I think it is important to consider why. Consider all other points first. I know several people that I've rung up, immediately they'll say to me, my medications need changing, my tremor's dreadful. But we know that tremor can be massively affected by anxiety and other factors. So it's important to see what they think is different. What do they believe has worsened? What's impacting on their daily life that they feel there needs to be a change there? Is it something else going on? It could be anxiety, stress, not having seen loved ones for quite some time. And sometimes in a situation like this, other comorbidities can take on a greater significance. Are there any side effects there? Or is it that the person's not having the response that they'd expected, and now that they're in this period where they can't talk about that readily with other family members, they become increasingly anxious about it? But I think it's also important to double check, are they taking them as we think they're taking them? And that's the thing. I would, when I'm talking to somebody, I would ask them to tell me what they're taking, not read out to them what I have on their repeat prescription. So I would ask them to say when they're taking them and at what times they're taking them. And I think in various areas, there are certain systems that can help us with this. I know some areas have a GP summary care record where you can look and say, when was this medication last ordered? Well, if it hasn't been ordered for a while, it would suggest that perhaps the person isn't taking it quite as regularly as they are, that you might think. But there are various systems like that that can help us with this assessment. So there are various factors that can influence this process. And I think anxiety, I think we can't underestimate that. Our patients become very reliant, really, don't they, on the therapeutic relationship that they can build up with us over time. And they do get very used to that face-to-face if it's what they've always been used to having. So they might be feeling increasingly anxious because of that. The anxiety can increase some of the motor symptoms as well. They can feel that they're not so well controlled. There can also be changes to their routine and support system. So somebody previously you might have popped in every day and given some distraction might not be able to come in. And they then might put all this down to that their Parkinson's is getting worse. So it's important to really understand exactly what's going on there. It's important as well that if somebody's saying things are worse, who is saying that things are worse? Is it them believing it, or is it the influence of somebody else who may not routinely usually be involved with them, a relative that's come to stay there, for example. I think, like Annette said, at beginning, at diagnosis, there's not always that urgency to start something. And what we decide to do may be very much based on the stage and the individual circumstances of the person. So at diagnosis, or maintenance, we may have had that chat and they may feel, well, okay, I carry on as I am at the moment, things aren't too much of a problem. But you may at that stage get somebody who says, no, I do need to change something. And this is where it becomes so individual. It all depends on the impact that whatever their problem is having on their general life. And that will influence what we need to do about it. This certainly becomes more of a factor as we move through the stages into the complex and the palliative phases. I think it certainly helps to have a structured approach. And I've adapted this from the Royal Pharmaceutical Society Practice Guide. And I think if you think about these several factors here, identifying exactly what's going on, gathering all the information from all reasonable perspectives. So if it is someone like a partner or somebody who usually is involved in care, it's very helpful to have their perspective. And I think what we all then are used to doing is having a plan, formulating a plan in our head and thinking, well, this would be a good option, that would be a good option. You consider all the options that would be reasonable, discussing them then with the person, and then looking at what is likely to be, under the current circumstances, something that you can actually achieve, agree, and something that's available as well. And having that discussion with them around the pros and the cons of each option, and then coming to a joint decision so that they're fully involved in that decision. And then when you've agreed that plan, again, recording it, saying all the facts that have informed it. So if something has particularly informed it because you're in lockdown, making sure that's recorded so that everybody knows. And again, the important thing is having that planned review, just as you would if you'd seen someone in clinic and said, you're changing something, they're going to come back in a month to review that, or telephone, whatever, that you still have that set planned date for the review and the evaluation, and reassuring that if whatever you've already done hasn't worked, but then you'd still, as in normal service, have a plan B that you would switch to, you'd consider. So there are lots of things that can help us with our medication review during this period. Remote assessments. This can really help to alleviate people to know that they're having that ongoing continuity from their specialist team. But I think during the height of restrictions, like I said earlier, it might be that we're trying to stabilise as opposed to doing anything too dramatic to try to massively optimise anything. There's lots of technology, and you can see some examples I've put here, body-worn sensors that could practically be worn on any bit of the body, the PKG, if you have access to those. There are various health apps and things you can download onto smartphones. And I think these are all fantastic ways that can inform our clinical picture of what we're being presented with, but it doesn't replace the clinician's knowledge, skills, and the patient's perspective of what's actually going on. It's something that can just inform it. I think as well, we have to remember that our patients may not always have the other technology, all this technology the other end. So while it's useful to have it, we still have to be able to offer this service even if they don't have it, and we might have to resort to the telephone. So the MDS have come up recognising the importance of telemedicine during COVID-19. And I think we all have to acknowledge that things have moved on leaps and bounds compared to whereas previously we might have been trying to set up these clinics and there were many hurdles in our way. We've known for some time, supported by the literature, the potential benefit of telemedicine, but it's been quite hard to implement it. So I think one of the positives of this pandemic is that we have moved on, as I say, leaps and bounds. The MDS talks about particular issues in relation to security and governance. Acknowledging the limitations, like Annette said, that you can't always feel rigidity, you can't determine rigidity, but there are ways that you can assess this. And I would just say that rigidity alone doesn't determine what you're going to do with somebody, it's just part of the assessment. So whether it's over the phone or ideally over video link, we're still able to do a good holistic assessment. And I think that's important. So when we looked at what patients and clinicians think about the whole process of telemedicine. There are various ways that we can do this. Annette talked very comprehensively about Attend Anywhere, and I know other areas they have something called a crux. I'd just be glad to have anything at the moment. We've done the training for it, but we're just waiting to get it going, because there definitely are limitations with only doing your assessments over the telephone. But of course, it's got to be secure. You've got to have all the governance set out around it. You've got to manage the patient's expectations, and I think it's about saying, as this paper highlighted, that the biggest disappointment were the technical issues that people experienced. So I think it's about having patience and perseverance and recognizing that this is something that could be helpful ongoing, not just now. Just to show patients' views is that they did like it, but that they found that some issues could be very difficult to talk about, particularly things of very sensitive nature, like impulse control behavior. So if we go, I talked about the percentages there, but you can see them for yourself. Annette touched on this, and it was particularly about impulse control information there. Very personal issues, particularly like hypersexuality, can be difficult to broach, and we would miss the visual cues if we were doing this over the telephone. So we still need to consider them, we still need to address them, and we need to really identify what's going on there. I did develop a telephone information checklist that I've summarised here just to fit it on the page, which just helps people to be prepared for their call and what they're going to talk about, including things like the impulse control behaviours. And the final slide is just the take-home message. Remaining patient-centred is crucial. Look at what's happening with the medications, what is actually happening, not just what you think it is. Remember that get it on time is still important, but the times that they're getting it might be different. They might be, their routines change, they might be sleeping later, etc. PD medications mustn't be stopped abruptly, so it's about prompting them to be making sure that they're putting their repeat order in enough time so that if somebody else is collecting it for them, there's time to do that. Stabilise, not optimise, always, and reassure them, record, and have your planned review. And there's the references on the hyperlinks do work. Thanks.
Thank you, Jane. These topics are really hard to cover in a short space of time, but that's really informative. A quick question, slightly related. It has come up for me actually during this COVID time, about how we could find out more quickly if a medication is going to be suddenly unavailable. We tend to find it out from the patients rather than other avenues. I've certainly had it recently. The orodispersible Zelapar, the sledgeline, is no longer available, and switching it has been problematic. So I know the PDNSA obviously circulate these things around, but
yeah, I think this is the importance of networks, isn't it? So for instance, where there has been a shortage, I mean, the Parkinson's and coronavirus booklet that Parks UK produced, they've got in there, what should you do if you're aware of a shortage? And it is inform. So there's a number in there that you can inform PDNSA, and we put that on our website. It's about getting the message out there, because what usually happens is that people will ring you at the last minute when it just hasn't come with their repeat prescription, and you're suddenly trying to look at what else you can do. But personally, what I've done with someone's rung me is I've actually rung the dispensing pharmacy and asked if they can try other wholesalers, if they can try other distributors, if you can go generic, if you can go branded, you can go whatever, looking at that way. But it's difficult, but it's important not just to know about it, it's important to share that message so that we get out there and we can plan for it.
Thank you. No, that was really helpful, actually.
Alison, can I just jump in? If you're actually registered for MIMS online, so MIM, you know, we've all got the BNF that we use. MIMS is the one that's used in GP land. As a nurse, you can register to be online for MIM, but in that, there has got a list of all drugs that are problems of distribution. So it's a really good way of actually seeing, you know, looking ahead about the medications that might be a problem with distribution-wise. And BNF don't have that, but MIMS, you can do that, and they can show you.
Oh, that's really helpful. Thank you. Thanks, Annette. That's some very good points about how we can take this forward. So moving on to Patsy now, she's going to talk about self-medication in hospital.
Okay, so I'm going to talk today about medicines management in hospital, and particularly around the ideas of self-medication management. My slides are wordy. They're very wordy, and I don't apologize for that. It's an awful lot to say in 10 minutes, and I was trying not to miss anything out. So without further ado, so the aim, so this is all our aim, isn't it? To ensure that all healthcare professionals who are involved with the delivery and care to people with Parkinson's are equipped with the knowledge and skills to deliver medication management on time, every time. Despite the fantastic efforts by Parkinson's UK, which has been going on for years, get medication on time every time, we still find from audits that many people who go into hospital unfortunately do not have their medication on time. Where to find the educational information and specialist assistance required to manage people with Parkinson's during an elective or an unplanned admission to your hospital can sometimes be very challenging. It can be challenging in the hands of the experts as well. But resources provided by Parkinson's UK, emergency information will assist in drug management, and also conversion tools, particularly with people who might be nailed by mouth. Or indeed, as we've just been discussing, perhaps if the drugs are not available. The people who are really important in this, which are frequently forgotten, and I think it's probably one of the most underused resources within the NHS, and that's our hospital-based and our community pharmacists. Early intervention in assisting with medication reviews is just so important, so helpful, and so beneficial to people with Parkinson's. When people are admitted to hospital, their carers and the people with Parkinson's, they are the experts. They deal with this 24/7. When people come into hospital, they are poorly, they are sick. And this I'm delivering to you from the mouths of our people with Parkinson's, that they need time to communicate with healthcare professionals, particularly in difficult situations like admissions to hospital. When people are unwell, it takes longer for them to speak, particularly if perhaps their medication hasn't been given on time or delivered properly. And we also have people who are going to hospital who are actually fearful of that admission. We also know that addressing these needs will improve the outcomes and also reduce the length of stay of people in hospital. And there are many, many papers that support this. Delivering medication on time, every time is our goal and my passion. So here we are, we're trying to make medication management a never event. And this is a little bit of work that's been going on behind the scenes. So a never event, I will read to you the definition. Never event should never happen in the field of medical treatment. Okay, so I just want you to hold that, okay. When people with Parkinson's don't get their medication on time, their symptoms can become uncontrolled. Sometimes the deterioration they experience can indeed be irreversible, leaving people permanently unable to walk or talk, and indeed changing their baseline considerably, and perhaps they're not being discharged back to their place of care and their preferred place of care. Even a delay in taking medications of 30 minutes can lead to serious health implications. The average person with Parkinson's may indeed find themselves taking up to 9 doses of medication a day. The timing of these medications are crucial. We know that ward rounds in hospitals don't always correspond with the timing of people's medications. And we also know with dealing with people with Parkinson's that everybody is different and their medication management regimes are different. As a result, people with Parkinson's miss out on vital medication when staying in hospitals, frequently for reasons unrelated to their Parkinson's. You know, people can be admitted to general medical wards, surgical wards, intensive care units, and perhaps there isn't always a specialist within that hospital. But as I said previously, you've got key people there, you've got your pharmacists, and you have your community pharmacists. As Annette was saying, you know, they have a brilliant system in Northumberland, but unfortunately, we don't all have that. So we might not always have a list of medication. And also, Jane, what you were saying, it's really important that we know what people were taking before they came into hospital, because the list might not marry. Okay, so missed medications on these wards are down to people having an in-depth knowledge. Okay, but that skill and knowledge is available when people are admitted. We also know that Parkinson's hyperpyrexia syndrome is a rare, but potentially and fatally complications, most likely by following reduction or cessation of medication. And the complications of Parkinson's hyperexia syndrome: acute renal failure, aspiration pneumonia, deep venous thrombosis, and the list goes on. And people who are working at the moment, particularly with COVID, when you look at those symptoms, some of them overlap. So there's a real caution there. So NICE guidelines update. I'm not going to go into the areas, we're all familiar with them. There's a consensus statement along with its supporting checklists, case for service change, and order dependencies. They outline the key medicine management issues that may face people with Parkinson's. We were fortunate before lockdown to go to the Care Quality Commission to knock on their door with Parkinson's UK, make them very, very aware about a clear guidance. Parkinson's medication is a time-sensitive medication. And under the guidance, which has been updated in 2020, they have now stated that stopping anti-Parkinson's medication can lead to severe side effects. And this includes non-malignant syndrome. They are stating that patients should receive their medication at appropriate time, but also key is self-administration where appropriate. A recent Freedom of Information report highlighted the fact that this does not happen throughout the UK. Indeed, very few hospitals do it successfully. And I am pleading with everyone who's listening to this today, all 170 of you, please, if it's working in your hospital, please let me know so that we can get the standard statement so that this will happen much more frequently. The other thing about having your medication on time and people with self-administration, it reduces nursing time, it's cost effective, better outcomes from our people with Parkinson's, empowerment, and also the fact that so many people prior to discharge, sometimes they're not even checked to see if they can actually administer their medication on time, and therefore we get failed discharges. Also, when medications are administered, they should be recorded on the records. I know I am probably teaching everyone to suck eggs, but the time is so important. If that patient comes in, perhaps maybe has been ill in the A&E department, hasn't had their medication, we need to know what time the last medication was delivered. Okay, in conclusion, a never event. We believe there is a wealth of resources, guiding and training to ensure that Parkinson's medication administration can be prompt in hospital. There are a number of hospitals throughout the UK who are excelling at this, and we'd love to hear who you are. Parkinson's hyperexia syndrome represents the worst instance of medical failure. And I do believe as well that this is very under-recorded because it is not recognized. We believe that making it a never event with the Care Quality Commission will see a clear improvement in how medication for people with Parkinson's is managed in hospital. Okay, I'd like you just to, you will have the slides so that you can go through them. I know that time is precious at the moment, but we have NHS Right Care, again, medication management in hospital. There's a range of guidance, resources, and training. We also have the Parkinson's Optimal Calculator. It's also signposted so that if people are nil by mouth, you have a way of delivering medication. right? Never event in conclusion, Parkinson's hyperexia syndrome represents the worst instance of medical failure. We believe that by making it a never event, we will see a clear improvement in medicine management, and we want to standardize the medication policy throughout the UK. If anybody has good practice, please share it. That's what we're all here for. If we give people, we empower them to have their medication on time, every time in hospital, we're empowering our patients, and hopefully we will make this a never event. Thank you very much indeed.
Thank you, Patsy. I mean, it's a massive importance, that topic, as they all have been, and it's a challenge, one of the major challenges. So thank you for raising that. We've got a lot of work to do, but you've done some amazing work. The CQC meeting and getting that into their documentation was a massive achievement. We'll move on now to Louise Ebenezer, who's going to do some case studies for us and covering some times that she's experienced during COVID. So that's very helpful. Thank you, Louise.
Afternoon all. Following on from the girls, I'm just going to cover a few case studies of what's been happening remotely, and a couple of one home visit, if that's okay. Tell me to stop if I go on a bit, Alison. The first case study is a lady. She was diagnosed at 57 2 years ago. She's 59 now. Past medical history of type 1 diabetes. Unilateral symptoms on her left, plus a whole host of non-motor symptoms such as anxiety, fatigue, restless leg syndrome, and constipation and REM sleep behaviour disorder. Unfortunately, she had recently been bereaved when she was first diagnosed, so that had a massive impact on her acceptance and why me, and the loss of her husband, let alone the loss of their ability because she's had a diagnosis of Parkinson's. She still works full time. She can work one day from home, but then commutes by the train into Cardiff. She was commenced on co-caraldopa 62.5 TDS. And in January of last year, her bowels became significantly worse, as did her sleep. And she was hypotensive, no postural drop, but her blood pressure was generally just in her boots. We did a 24-hour blood pressure recording just to make sure she didn't have supine hypertension, which is quite common in Parkinson's. And also you want to rule out a red flag of maybe an MSA in the future. And she was commenced on Rizagiline and Laxido. So that was pre-COVID. So that was her history. Pre-COVID, so from May till October last year, her mood hasn't improved very much, neither has her anxiety. Feeling extremely dizzy all of the time. Which again, red flags, because she had a little bit of mini myoclonus on her fingers and some bluish tinge, and then she started to have a postural drop, which was minimal because her blood pressure was very low anyway. So we stopped her Rizagiline. Her REM sleep behaviour disorder was getting worse because she found herself on the floor, but she'd been reluctant to take her clonazepam because she was fearful of not waking up and getting to the toilet on time. And again, in the background is her grief and her non-acceptance, her diagnosis. She has had counselling through work, which is helping her. So since COVID, so from March to May this year, she's now struggling with self-isolation because she's working from home completely. She's struggling with lack of exercise. As much as she's tried to do some PD Warrior and the exercises on Parkinson's UK website, she hasn't got the motivation at home. She's now taking co-caraldopa 125 3-hourly QDS. Because of fear of bladder problems, and because she was having significant wearing off, we've had a long discussion about where we're going to go in the future with her. So I've done some email correspondence with her and some telephone. We haven't attended anywhere. It's about to start next week, as is our face-to-face appointments. I commenced her on a pick-a-pone because of her fear of incontinence, and she's still a young lady. I didn't want her to have that awful staining of her orange urine. And we've been able to reduce her Cinemet to TDS. Her dexterity has improved because she's typing all day on the computer. She's noticed that her left hand, she can flow through the keyboard rather than being stuttery, and she's far less dizzy. Would I normally put her on a pick-a-pone as a first line after wearing off? I have in a few. I haven't always gone down the entacapone purely because of bladder problems. She's not incontinent of urine at all, but she's very fearful of it becoming a problem, and she's young, and I don't want that staining to be an issue for her. I spoke to her last week, and she's doing very well. She's had another prescription for the next 3 months for a pick-a-pone. She's starting to feel a little bit happier in herself, and generally far less dizzy, because in the back of my mind, this lady was potential an MSA because of all her non-motor symptoms. But actually, she's far less dizzy and she's far more capable of doing things. Interestingly, she couldn't take Madapar. When we tried her on dispersible, she just said it doesn't agree with her, and she couldn't tolerate it. And she's a very sensible lady. But, you know, underlying, I don't know how much grief is having a huge impact on this lady, and loneliness and isolation. But she's doing okay now. The next gentleman is in his 70s now. He was diagnosed in 2004. So I'll just give you a brief history, and then I'll do pre and post, pre and during COVID. So very little past medical history, hypertension and raised cholesterol. And there's his medication currently. It's what he is now. I'll tell you his medication before what I've changed during the to get to this stage. He had a mocker done a year ago because he was in our synapse study for sulfonamide. That's why he's on it. And his mocker was 26 out of 30. So for 16 years of Parkinson's is pretty good going. So in March this year, just before COVID, he came into clinic with increasing freezing episodes leading to increasing falls. His mobility was deteriorating, lots of short, shuffly steps, couldn't get through a door frame at home, and had fallen in the garden, and he loves gardening, and the emergence of some visual hallucinations. He had a urine dipstick in clinic purely because he was admitted into another hospital a year ago with urinary sepsis and had quite a nasty, torrid time in hospital. His cognition was reassessed in March this year, and it was only 17 out of 30, which is quite a high drop in a year on his mocker. One of the consultants had reviewed him and reduced his ropinol. And we have a complex clinic that we sit together with our patients when we're going to assess non-oral therapies or introduce cholinesterase inhibitors for Parkinson's disease dementia. So he was booked into that. So the end of March this year, I had a very distressed call from his wife that he had massive increase in visual hallucinations. He was very disorientated, feeling of presence, and occasionally he didn't know who his wife was. Where am I? Bowels extremely constipated, mobility had deteriorated further. So I reduced his sulfonamide from 100 to 50 milligrams. And was there rationale to do it or not? I switched him from ropinol to rotigotine patch because I just feel it personally gives better delivery, smoother delivery over a 24-hour period, especially when people are developing hallucinations. And then I started reviewing him a month later. So April, his hallucinations had almost resolved with the reduction in pills of the agonist and the sulfonamide. His freezing had improved because he'd had queuing strategies, and I'd reiterated those over the phone because he'd come to our day hospital. He'd also undertaken PD Warrior. May I reviewed again, and he was significantly much more improved. However, he can still be disorientated on waking. Interestingly, his friends, when they call him, felt his speech was much better rather than it being quite slurred, that it was clearer. So I rang them last week. He's had one fall in the doorway. And his wife can't say why, because when I talk to them on the phone, I talk to them together so that they're both in the same room and they're both chatting together. His mobility is still variable, but he can get into the garden. He can't bend down to plant his plants, but he can still physically dig. His sleep has improved. He probably has 5 out of 7 good nights a week, but still is disorientated on waking. Bowels have improved on Laxido. We're starting face-to-face clinics next week, so I booked him in because I want to do a mocker to assess his cognition and an ECG, and I want to look at him walking and give him a thorough assessment. But I just showed it is harder to deal with people over the phone with cognitive or the emergence of cognitive impairment. But him and his wife have done everything together. They've always come into clinic together. So the telephone call, I didn't feel I was just having her opinion. I spoke to both of them. Is it time for the last one or not, Alison? So it was only about putting somebody on apomorphine during COVID and going at home, and risk assessment. He was planned to do it before, but his wife was poorly, so it was delayed. All I'm just saying to everybody is risk assess. He was on pens, I switched him to pump, and he's done it extremely easily. And they're quite happy to see you at home. Obviously, he hasn't got COVID, he's not shielding, and I don and off in and out of the house. And it worked very, very well.
Thank you, Louise. Sorry about that. I think your previous case study brought 2 things to mind for me, actually. One, I'm managing Kath Parry's patients at the moment, so I've been in touch with a lady who's having a lot of hallucinations that have been increasing over the last couple of months, and she's actually on ropinirole. So I've tried lots of things, and she's not coping with cholinesterase inhibitors. So I might go that route, because the last thing we want is that to be a reason to come into hospital, isn't it?
Exactly.
I'm muted. The other question is, it came through previously, it was about rotigotine and whether or not we're seeing more people using rotigotine and other patches now rather than oral medications.
I don't know. I've always used rotigotine. I've always used the variety, because at the end of the day, it's always about the history of the patient. It's patient choice. You explain the oral agonist and what the patch is. I don't know if it's on the increase or not. It's no different than what I've ever used, whether it's Pramapex or Ropinirole or rotigotine in my practice. I don't know if anybody else has got another opinion on it. It's about.
No, I agree.
Always. Yeah.
I think I definitely find that there's, it's used a lot when patients are inpatients and there's a concern about swallow. My go-to is an NG, preferably, or different method of giving their medication, but obviously we don't always have control over what happens in the evenings and weekends and everything else. So I'd rather they were on the rotigotine than nothing.
With lots of comorbidities, or you see for the first time, and they're on a whole host of tablets. I don't want to take any more. Sometimes it's easier to use a patch rather than oral medication.
I'd like to add, though, that when they are people with Parkinson's are admitted to hospital, and so many times I go down to various wards and I see where there's a conversion to the patch, the rotigotine patch, without using any kind of method. So I would always say, start low and go slow, and look at your diagnosis, look at your patient. It's always suitable.
No, I think that's very good advice, Patsy. That the transition between the different doses, between oral and the patch, cannot always be well executed.
Can I add, with the selegiline question you asked earlier, Alison, all the pharmacists rang me to say they couldn't get it. It didn't come from the patient, it came from the pharmacists.
Okay.
I either give them a choice of switching to oral selegiline, switching to risagiline, or just coming off it and watching to see what happened to your symptoms, then altering your levodopa.
Yeah. No, and thank you. No, I think mine did come from the patient, and I've actually had a colleague ask on behalf of somebody that they know, but we switched to Essentially, and it just wasn't the same.
No.
So, but yes, it's we're so busy as well, aren't we? So always seeing the, you know, notifications and things. Unfortunately, you know, patients might get to us first because we tend to phone a patient back before we do anything else, and we get a phone message, don't we? Thank you, everybody from the panel, and thank you to all of the participants who obviously make these events what they are. They raise the topics, they raise the questions, and they make them meaningful. So thank you, and thank you to the Academy and to BIAL, of course.